I'm now pleased to introduce to you Dr. Gagandeep Singh, a surgical oncologist from the City of Hope in Phoenix. We know him well because he used to be in Los Angeles, that's where I live, and he's moved out here. So those of you who live here, you're fortunate to have Dr. Singh out here. He's going to give a presentation on surgery for neuroendocrine tumors, to cut or not to cut. And a fun fact about Dr. Singh, he collects computer chips and makes art with them. So he's shown me there's one of the pancreas, one of the liver, and one of the gallbladder. Dr. Singh, welcome.
Thank you for that introduction, Lisa. Thank you for the invitation. Heather, thank you for staying on top of all the emails and back and forth and making sure I get it to you in time. So my slide deck is probably not for the faint of heart, okay? It's got some pictures in the operating room. So if that makes you queasy, please look down when it comes up. There are quite a few in between over there. And I think I've probably put way too many slides, so I'm going to go through them a little bit fast, but always here to answer questions for you. A little bit of a roller coaster ride, so let's keep moving. I don't think it's about to cut or not to cut. The most important thing to remember is when not to cut, because that's the biggest mistake surgeons make is, oh, I can take this out, but you make the life of the patient miserable, okay? And when I say that, neuroendocrine tumors, you're living with it. So I say living with neuroendocrine tumors, learn to adapt to it because quality of life and longevity are key. If we take that away from you, then we're not doing the right thing. So, oh, I'm sorry. That's yeah, that's all right. So with that said, let's keep moving. I am going to focus predominantly on the neuroendocrine tumors of the gut. I do a lot of work on the pancreas and the liver. That's my forte. And then with neuroendocrine tumors, I do a lot of work on intestinal work, which people don't want to touch. So often it's more small intestinal because the colorectal people will touch the large intestine. And I'm going to start with this story, and this is what actually changed my thought process to neuroendocrine. So this is an undergraduate, 19 years old, 2007, comes to me with a tumor in the pancreas head, extending into the pancreas, had 2 liver metastases, okay? Opinions from the Midwest, opinions from the East Coast. One said put long-acting somatostatin, the other one said give radiation and long-acting somatostatin. And then came to me, and we'll talk about this as we go through it. But nobody was willing to offer a surgery because the tumor was actually involving the vein that goes up to the liver. And this is the entire blood coming from the intestines, which is 1.5 liters per minute of blood, that goes through the notch of the head of the pancreas and goes up to the liver. And this was completely occluded, as with the vein going from the spleen down here, which is completely occluded. So you think, how can a 19-year-old have something like this? And then the next year I saw somebody who was 18 years old, and that changed my thought process for patients with neuroendocrine disease. So that became a sort of an obsession for me to figure out what was going on. And some of you have heard me talk about this in the past. I've done a lot of studies, pollution studies, studies in California looking at areas where they're coming from and trying to look and figure out what is going on. But what we really need to figure out are which are the ones you want to attack surgically. So with that, I will say what Dr. Sandbal just said is the well-differentiated is what you want to run into surgery with. The ones that are slightly harder are the ones that are well-differentiated grade 3s and the poorly differentiated. And I've written on this as well because there are patients which will lend themselves to surgery, but they have to go through the motions of getting chemotherapy or controlled systemic therapy up front before you can bring them to the operating room. So it's not a no-no. And this is just to give you an idea from the slide what a well-differentiated looks like. Very little brown within the tumor. This is also well-differentiated, a little bit more brown, so a little bit more aggressive. This is the well-differentiated still. This is now getting into grade 3 well-differentiated, and this is going into grade 4, or what we call with some amount of necrosis. So you can see the more brown there is, more activity of the somatostatin receptors there is, the more likely that this is going to be a little bit more aggressive. So we have to base ourselves on treatment for surgery upfront on the ones that are within this category and sometimes within this category. These two, we want to bring them here before we take them to the operating room. Now, of course, if they're functional, it's a no-brainer. If they're symptomatic, it's a no-brainer. They need attention because their quality of life has completely been jeopardized. So you want to take this patient population that's getting up in the night, getting up in the night and having diarrhea. Okay, they get up 3 or 4 or 5 times in the night to go go to the restroom. And then flushing, which Dr. Sandbol talked about, is not, perimenopausal flushing. This is flushing that has no sweating associated with it. And this is another type of flushing that you have a sip of alcohol sometimes and you start turning red and you start getting flushed out. So it's a little bit different than the normal. And then, of course, there are other symptoms as well. And if you're truly symptomatic, you definitely are going to buy surgery to cure this if it is possible to control it with surgery. Now, the reality is up to 70% of these tumors present with liver metastases first. So the liver needs attention as well, unfortunately, in this patient population. And so that's where my interest started. Now, within the pancreas, 30% of these will go to the liver. Within the small gut or the large gut, almost 70% of these will go to the liver, okay? And so the question is, should you control the primary and the liver at the same time? Yes, you can. You go to the right specialist. If it's possible, he'll do the right work, or she'll do the right work at the first time that they go in to do it. Sometimes it's not possible. You need to reduce the burden of disease in the liver and then go in a staged fashion to the liver. And I'll show you in a second the data again that we published to sort of show that. Now, one of the most important things, and I get this repeatedly, is what is the best test? Should it be a CT? Should it be an MR? Should it be a PET scan, gallium-68? I'm fond of MRI. I'm really fond of MRI because it picks up a lot smaller disease. But I think each one of these is complementary to the other. So not one of them is completely absolute. So go with the flow. Sometimes you feel you're getting repetitive scans, but it's important because we're trying not only to gauge the amount of disease, but what we're also trying to gauge is the burden of disease, or is it beyond one organ? Is it in the second organ? Is it in the third organ, et cetera, et cetera. So those are places where we use different types of scan. Now, the reality is, if it's a localized tumor, they have a better 5-year survival or 10-year survival. If it starts going to the lymph nodes, we drop this. If it goes to liver metastases, it again drops further. Now, this is from 2008. We've gotten much better with this. So what we want to do is reverse this trend. So we want to be proactive on treating the liver. We want to be proactive on getting the lymph nodes, and we want to try to get the primary at the right time, okay? And so that's the whole basis of treatment here. So if I see this, just a lymph node in a person in the center over here, I know that this person's got a primary somewhere else. I need to figure out where it is. And most probably this is going to be either in the stomach or it's going to be in the pancreas. So I'm going to do 2 tests, find out where it is, because it's already moved to the lymph nodes. Let's go after it. Now, having said this, I want you to remember one very important thing, is that in some of the older patients, it is wiser not to be too aggressive, okay? If it's somebody that's 40 years of age versus 50 years of age versus 70 years of age, the treatment is going to be completely different. You don't want to do something too aggressive in a 70 or an 80-year-old person. But if you know that there is a 40-year-old person with an aggressive disease and you know that this person is going to have a hard time reaching 60, you need to be proactive on that particular patient. And again, there are 80-year-olds that ski, and there are 40-year-olds that come in a wheelchair. So everything has to be taken into perspective when they come to your doorstep. So I always say surgery is the gold standard, but you need to balance this out. And again, not overdo it for your patients. So you have to balance out when you're going to do this. You need to take out the primary, you need to take out the nodal mass, you got to treat the liver, and you've got to take out the gallbladder if you're in the belly, if you're going to need additional treatment, because one of the medicines does affect the gallbladder emptying as well. And I always say be prepared for what's called a crisis or an acute exacerbation in the operating room. Now, very important, I want you to, look here. It's really tiny tumor on the intestine. There is no test in the world that's going to pick that up, okay? And this tumor has got liver metastases and it's got a nodal mass here. So this nodal mass is prompting me to now look on the intestines and actually offer this patient surgery because it's already begun to move. So again, it's a difference in thought process. The East Coast and the West Coast are a little bit different on this. There are trials going on to prove what's better. But at this time, we're kind of proactive if you see it. Now, the other thing is, why do you want to be proactive sometimes on even such a small disease here? You can see that it's in the small intestine. It's going to ultimately completely occlude the small intestine, so nothing's going to pass through. And then they start pretzeling. What I mean by pretzeling is, the intestinal loops start getting stuck with the nodal mass. And so they start getting twisted and becomes harder and harder. So when they come to you at a later stage, instead of taking out 2 feet of intestine or a foot of intestine, you're taking out 3 feet of intestine or 4 feet of intestine because they're all pretzeled into that central nodal mass when they come to you. So it's a balance again. Within the pancreas, there are several different operations for neuroendocrines, and you'll hear this in a couple of the examples as I get towards the end. The head is called the Whipple, the central, which is just the central portion of the pancreas, and then you take out the tail and the body of the pancreas with the spleen, which is called a distal pancreatectomy with splenectomy. Now, a total pancreatectomy for neuroendocrines is very rare, but you will sometimes have to see it, or you will hear of this in this patient population. Treating liver metastases. Now, it's all about size, location, and number. And I'm going to go through this really rapidly. Clearly, you would say, oh, you cannot treat these. I tell you, these are a piece of cake because you can actually take these out, even though they're large metastases, because you can carve these out, preserve the blood supply there, carve this out, preserve the main blood supply here, but this, I cannot, okay? And so this is the patient population that you need to basically have a strategy as to how you're going to control. So when you have liver metastases, somebody says, oh, he didn't want to do surgery. Not all liver metastases are cut alike. So you have to balance out how you're going to approach these. And so we classify these liver metastases into type 1, type 2, type 3, and type 4. I'm going to show you examples. And again, I'm going to run through this. I would say type 1 and type 2 are easily resectable. This is not, but it still can be sometimes when you can judiciously downsize some of these. And then this is purely for palliation. Again, I'll show you an example, and then you'll understand what I mean by palliation. You cannot sometimes clear out 100% of the disease. What we found is that if you clear up to, it keeps moving. If you clear up to 70% of the disease, whether it's anything more than 70% is equal to 90% in terms of survival. So the goal is now 70% debulking is good enough in neuroendocrine tumors. So that's what we typically live by and try to achieve in this patient population. Now, this was the pivotal study that we published back in 2019. A lot of controversy, went in one of the top journals, Annals of Surgery, and I want you to look at this. So this is the primary tumor, which was completely untouched, and the liver was untouched, okay? This patient population, obviously, you can see that 5-year survival in this patient was less than 20%. Then you look at the primary tumor was untouched, but the liver was treated a little bit better, okay? But here's just the primary tumor alone, the one that's actually throwing out all these satellite nodules. Taking that tumor out alone is better than working with the liver. Of course, if you work with the liver and the primary, you get the best survival on this. So we have tried to push this pendulum, and again, this is retrospective data looking at the California Cancer Registry. We had almost 1,000 patients, so we were able to balance this out. Again, I run into controversy with a lot of my colleagues sometimes who want to just observe this patient population, but they're the ones who come back with more problems later on. I know I'm running out of time, so I'm going to just kind of run through some of the important stuff. There are several strategies on liver work, surgery, there's transarterial embolization. I think the next speaker is going to talk to you a little bit about that. Transarterial chemoembolization, radioembolization, et cetera, and of course chemo. So there are several ways to reduce the size of the tumor. There are several ways to increase the size of your liver also, so that you can work with them, and that is, the liver has about 1.5 liters per minute flowing into it. If you block off one of the main blood vessels going into this, and you move 1.5 liters going into the left side, this will then lead to a compensatory increase in size by almost 18%, somewhere around that 13% or so. And then if you block off what we call the outflow of the hepatic vein on the top, concomitant, and this is without going to the operating room, our interventional colleagues will do this, you can increase the size of the liver almost up to about 27%. So now suddenly you improve your playing field to be able to achieve that 70% debulking within the liver that you're going after in this patient population. And again, I'm going to sort of run through this. I'm going to skip some of this because I am being told I'm out of time. There's a very drastic procedure as well where we completely divide the liver in the center and we leave it in the body. We've completely devascularized one side and left the blood supply going to the other side. And this basically is called disruption of the liver, which actually leads to the maximum amount of liver growth, somewhere between 40 to 80% within 9 days. And then it sort of allows us to work with the liver. But this has a very high mortality and a morbidity associated with it. So we're really cautious because 1/4 of the patients will not tolerate this. And so I always treat this as a last resort and only if you think it's safely doable, because if you look here carefully, the morbidity is very high and the mortality can be as high as up to 23% in different series. Neuroendocrine tumors, where patients are going to live a long time, you don't need to go crazy. You need to find alternative strategies to control the disease rather than use everything up front in this patient population. So moving on, these are all examples, and again, I'm sorry because of the lack of time, but just to show you, big tumor in the liver, big tumor in the pancreas, and we're able to actually take these out. These are all my patients, so they're no privacy, hopefully here, no identifiers. Again, this is multiple tumors within the liver. This is an easy debulking case as I look at it. Again, this is another patient with a functional neuroendocrine tumor from the pancreas, multiple tumors in the liver. Again, easy to clear out. The liver regenerates beautifully. The type 3 is the tough one, which I told you about. This is the one where just taking out that primary controls the metastatic disease. Now, this is 7 years out. Look at her liver. All I'm treating her with is radioembolization. Now, here's the thing that I want you to take home from this. This is a patient before PRRT was approved in the United States. Okay, she had the means, she had the financial means to go to Europe and get PRRT because our report kept reading there's an odd growth of a tumor here, there's an odd growth of a tumor here, and she was always worried about it. And I told her, don't rush into this. You're doing extremely well. Quality of life is great. But, the European data was compelling. People flew across, the pond to get treatment in Europe, and she came back, and you can see this liver is now completely shrunken with water around it. This is a fully cirrhotic liver, and she actually died on our doorstep with us looking after her 6 months later. So, you have to balance out what you're going to do for these patients. You don't want to rush because we've already radiated the liver with Y90. Balance it out, talk to your providers, and go gradual. Don't throw everything at the patient because this is another patient that should live forever, basically. Because I look at it, with that liver, she would have gone on really well for a long time. Patient with these 2 dots, and the rest of the stuff is controlled. I tell patients, just take a deep breath and go with the flow. okay? Don't go crazy over anything. If you want to get the long-acting somatostatin, perhaps that's fine, but you don't need to be super aggressive. This is a tough problem. Here you have multiple tiny dots, which are like 1,000,000 spots on the liver. It's miliary disease. This is what you need PRRT for. This is what you need Y90 for. This is almost impossible to control surgically in this patient population. And then the last, this is for palliation. As you see, this is a large tumor here that this gentleman was presenting with, and that's the size of the tumor. It's purely done for palliation, sorry. I think somebody's dulling the slides, but again, basically done for palliation, just to give the patient symptomatic relief. All right. All right, I'm going to go through the NET team. So surgery is the gold standard. A lot of this can be done robotically. Most of it is done open still. You need to remember that you need to go with your provider's preference for your particular disease. Don't push, say, I want to get it done minimally invasive, or I want to get it done robotically, because it's a balance between how much and what needs to be done. So you need to go with the gut of your provider. This is just a little bit about robotic surgery. I am going to rush through this so that I don't take too much time. A word on histotripsy. All right, this is the new toy in town, and this is basically getting rid of liver tumors without actually opening you up. I think it's promising technology. It is at this time approved for 2-centimeter tumors. You cannot treat a liver like I showed you with those multiple liver metastases, but if you have a solitary met in a critical area, you could definitely enroll for this. It got FDA approved last year in November. I've actually visited the company, looked at the technology. It's very compelling, but there's no data at this point to tell us that this completely kills the tumor. We're waiting for that data to accrue in the next 2 years. So wherever you go for this, it's going to be experimental to a large extent. So remember that when you're enrolling for this. There are more definitive ways of controlling a 2-centimeter tumor. Put a needle in it and have the interventional radiologist who's going to talk to you next, just completely burn it. Done. You know, that's a 100% cure of that treatment. But this is going to be a little bit experimental. It's going to be completely non-invasive. Yes, we want to be a part of this, but that we can't rush everybody into this. So we have to think about this as we go there. And this is from their website, which is showing the tumor, which is about 2 centimeters in size, which has completely been treated. And this trial was done in Spain. So it's very intriguing, but definitely not for this patient. Okay? So again, people keep asking, why not histotripsy for my liver? Because not all livers are cut alike, and not all liver metastases are the same. Lastly, so this was the 19-year-old we talked about. So ended up on my doorstep, and if we wouldn't have operated, 10 years later she would have had more liver metastases because the primary is still inside, and the primary would be completely unresectable. And I did choose to go in and operate on her. And this is her 18 years out, and she continues to remain disease-free. So I think there's a balance in being aggressive, and that's all I'm trying to say. Thank you.
Thank you so much. Wow. You can see each of these speakers have such a wealth of knowledge, and we have a video online with Dr. Singh if you want to learn more about what he's talking about with liver resections, liver tumors.